All right, Brett, take it away.
Awesome. All righty. So we have a case. This is a patient, it's a 43-year-old male. He has recently diagnosed with hypertension, type 2 diabetes, and hepatitis C, who presents for evaluation of about 2 weeks of intractable diarrhea and polyarthralgias. So the HPI, brief HPI on him. So this gentleman was in his usual state of health until about 2 weeks prior to presentation, when at that point he began developing non-radiating periumbilical and lower abdominal pain that was associated with persistent fevers, diarrhea, diffuse myalgias and arthralgias, and loss of appetite. So he says the diarrhea, he had about 5 or 6 episodes of yellow-brown stool with rare appreciation of frank hematochezia over the last 2 to 3 days, and that he potentially had darker stools early in the course. He's never had any endoscopic evaluation, and it occurs irrespective of his PO intake. And he also had intermittent nocturnal episodes of diarrhea. He denied any associated nausea or vomiting. He had no incontinence and no dyspepsia. In regards to his myalgias and arthralgias, he said it's most pronounced in his bilateral knees and his legs throughout, and has also had intermittent numbness and tingling and pins and needle sensation in his distal extremities. So he's had very, very dark urine, but no dysuria or gross hematuria. And then otherwise on his review of systems, notes some intermittent night sweats, but doesn't denies any weight loss, no rashes or lesions, and no recent sick contacts. And so with that plethora of information, we can kind of stop there and digest.
Wow. Poor guy. This sounds like it hasn't been an easy couple of weeks, and thank goodness he's here, right? Um, so somewhere in Chicago, Kirtan just stopped what he was doing and felt like someone has said his name. And that was before I actually said his name. Um, I think, yeah, just curious actually what everybody is thinking, whether, people sort of are looking at this all together and sort of potentially recognizing a syndrome that could tie everything together, or if some people think it's better to sort of organize the approach and differential around one of the features, and which feature y'all think is the most, I don't know, notable or specific or severe. Um, what are people thinking?
I don't know if you saw Andrew's points, which are really great, Zavin, that looking at this all as a syndrome, the fact that there's new onset paresthesias in this set of symptoms, the fact that there's blood with the diarrhea, suggesting inflammatory etiology, and then these kind of painful muscles and joints. It's indicating possible multi-system condition. Um, I would say, though, to answer your question, like, this is someone in whom I would make a problem list and would tackle it all separately first. Um, I was just sort of quickly thinking about what is the problem list that Brett has given us so far, but as a way to sort of organize, think about each one, and then potentially see where the overlap is. It's still acute onset diarrhea with this duration. Acute onset bloody diarrhea, I think, is important because, as I mentioned earlier, based on Andrew's suggestion, inflammatory etiologies are there. There's the associated myalgias and arthralgias in the lower extremities. Presumably, Brett, this kind of numbness in the arms and legs is new also. There's inflammatory symptoms. And then you gave us a tidbit of background early on, which is recent new diagnoses of diabetes and hypertension. You mentioned that as the first sentence, and I think it's worth saying, like, is it remarkable this guy was just newly diagnosed with diabetes, hypertension, all at the same time or not? I think for a 43-year-old gentleman, depending on his access to care, not really, right? Those are just very common conditions unto themselves as primary disorders, elements of metabolic syndrome. So I sort of put a pin in that, saying, okay, he's recently been diagnosed with those conditions. Now, whether they all tie together and whatever's driving his kind of acute, very troublesome symptoms is also in the background for those conditions is something we can consider. But right now, I would sort of make that a separate condition of newly found, presumably chronic conditions that are there. How are you tackling this, Savin?
I think it was hard for me to not kind of see it all together, but I agree there's definitely I mean that could give you some efficiency potentially, right? But there's also a way to miss things. I think if I were to sort of slow down and think about like the acuity and everything, like I think this is one of those things that yes, technically it's not yet chronic diarrhea, but everything chronic starts with acute before it turns chronic, right? And it's still the same sort of process. And I think that's where sort of some of those additional features that you could call red flags or whatever, but like that are just hard to necessarily tie with infection come in. Most acute diarrhea is infectious, right? Whether bacterial or viral. But the amount of kind of systems, as well as the fact the time course already that's a little longer than most acute infectious diarrhea, 2 weeks. It's not the 3 week cutoff, but again, that cutoff is artificial, right? And the closer you get to 3 weeks, you're already sort of the weight is starting to shift. But can you get arthralgias or even arthritis from infectious diarrhea? Absolutely. It could be part of a viral syndrome, or it could be a post-bacterial colitis reactive arthritis, right? I recently saw a patient who had very inflammatory oligoarthritis, large joint oligoarthritis after salmonella with some delay. But then there's the sort of possible neuropathy, right? And you're like, huh. And then there's the sort of persistent, it seems, fevers and systemic symptoms. And you're like, huh. So it's getting to be I think you have to start thinking about non-infectious things, autoinflammatory processes, autoimmune processes that could potentially tie together, systemic inflammation, a lot of center of gravity in the gut, the joints, the nerves, the kidneys. I think the urinalysis here is critical, right? Because the dark urine is like, okay, you've been having a lot of diarrhea. Are you just a little bit dehydrated? But if you have cells and a lot of protein in the urine, now you're definitely all the way over in the sort of vasculitis category, hence the kirtan spidey sense wherever he is in the world right now, going off. So I think this is one of those things that kind of bridges two worlds. But to me, the flavor is much more in the sort of immune system rather than infectious. And then of course, malignancy is kind of in the background, but for that, the time course and a sort of explosive syndrome doesn't really fit. Steph, question back at you and everybody else. I had sort of like ignored the recent diagnosis, so maybe we can also ask Brett, like, this was recent diagnosis in the context of what? Like he just decided to go to the PCP three months ago, or he was also having something else? And then curious if everybody's tying together those particular recent diagnoses, hepatitis C and potential metabolic syndrome, into what's going on now.
Yeah, good question. So that kind of goes into aliquot too. So we can just kind of talk about his past medical history. So he had not had contact with the healthcare system in several years due to a lack of insurance access. So he, during this time, during this acute presentation, about 3 days prior to his presentation in the hospital, went to an urgent care, had just like a generic panel of labs ordered, and essentially just left that visit with those three diagnoses, with really no other information available to us at that time. And then so he left, so was given those three diagnoses, left with a prescription for enalapril and HCTZ. And then that was, which is the extent of his medications with no other herbs or supplements. And then I can finish off the rest of the history components I can give you a chance to jump in there first though.
I'll go ahead and finish off the rest of that back history.
Perfect. No pertinent surgical history. Family history denies any known family history of any autoimmune diseases, malignancies, any sort of atherosclerotic vascular disease, no known drug or food allergies. And for his social history, he said he smoked about 1 to 2 cigarettes for maybe 1 or 2 years, but has quit at least for the last 20 years. We'll have 7 to 8 beers during social occasions, but it's fairly rare and it's about once every 2 to 3 weeks. Lives at home with his wife and daughter, works in landscaping. He immigrated from Mexico about 10 years ago, but says he's not left the state of Georgia since that time. No pets in the home. And then I think as someone commented on the chat in regards to his risk factors for the hepatitis C, denies any history of historic blood transfusions, has been sexually active only with his wife, denies any IV drug use or any other illicit substance use, no tattoos, and no pets in the home was the only other thing I think we had from his social.
Great, thank you. So really kind of engaging very recently into care for various reasons, and feeling unwell at the time too, in addition to getting those background diagnoses. There's some discussion in the chat just about the significance of the new diagnosis of hepatitis C. So that might be worth sort of thinking about a little bit. Oh, I don't know if you can tell us now, Brett, or not. Was this like active hep C in terms of a high viral load that was evident with ongoing chronic infection, or looks like more he had spontaneously cleared it? Because that's an important sort of mark in terms of thinking about what the potential contribution of that back history could be.
Yeah, so at the time, when we have this diagnosis, we don't know. Later in his workup, he has a positive hepatitis C viral load at 93,000.
Yeah, I think just briefly chatting about sort of chronic active hepatitis C, of course, first and foremost, the associated liver complications that can come with that. Of the viral hepatitides that are lettered, the least likely one to cause an acute hepatitis, but very, very frequently not cleared, leading into chronic complications of, as we know, liver inflammation and injury to cirrhosis. I think we've started to unpack in the chat some of the extrahepatic complications of hepatitis C, including small vasculitis related to cryoglobulinemia is listed on there. But Zaven, help me fill in this list, or everyone else on the list, help me sort of fill in the list. Just a lot of other things can happen. A lot of dermatologic manifestations can be associated with chronic untreated hepatitis C. I think one of the classic ones that at least I haven't seen as frequent is the porphyria cutanea tarda in the photo-exposed areas of the skin, kind of getting those scaling and erythematous lesions. But I think generally a lot of chronic dermatologic conditions like implantus, et cetera, can be activated by it. Correct me if I'm wrong, Zaven, but just peripheral neuropathy alone from hepatitis C, I think, is possible as well as potential joint-related manifestations outside of actually having the small vasculitis of cryo. What else would you add to that list?
Obviously, you said extrahepatic. I can't think of much more, Steph. Sort of renal limited vasculitis, specifically membranoproliferative GN, another sort of route of immune stimulation and organ effect. Yeah, I think I for all of those is a good review, and they explain some, but to me, not necessarily all of the findings, right? Like this is all happening at the same time, and it's all sort of prominent. I think except for cryoglobulinemic vasculitis potentially affecting all of the above, potentially kidneys, nerves, gut, joints and systemic inflammation, which it can do, I don't I think that's the main mechanism that I can use to tie to hepatitis C, not others. You know, Andrew had said something earlier. Oh, here, he clarified my question. In my head, cryo is more indolent process that is not so inflammatory, like this with fevers, prominent diarrhea. It doesn't fit the Gestalt script for me. Yeah, Andrew, I think I think you're right. I haven't seen that many cases, but I think the sort of my Gestalt script is kind of like yours too. But because of the small N that I have, I want to use a lot of illness script flexibility and still potentially have it on the differential and you know want to consider it and actually to test for it, quite frankly, especially if the UA or the creatinine sort of pans out with renal involvement, or if there's like, you know, small vessel vasculitis evident in the skin with petechial kind of purpuric lesions, etc. Um, yeah, I think I'm also just still intrigued by the time course. You know, it could be coincidence, but the other thing that, you know, I want to kind of react to that Brett sort of mentioned is always, you know, you kind of think of past medical history not only as sort of risk factors for disease, but risk factors for a treatment that can lead to disease. So I don't think of what was he started on, enalapril and HCTZ as sort of medications that are, you know, particularly immunogenic or otherwise sort of associated with like a systemic syndrome like this, but you know, but they can there can be, I think, ACE inhibitor, I don't know, bolus associated or triggered bullous pemphigoid, for example, right? Or drug-induced pancreatitis. And so I would still sort of want to keep one eye on that med list as a potential sort of a global narrative explanation of the sequence of events here, although nothing's really pinging based on those particular drugs.
I guess before we move on, sort of where are we now? We've talked a lot about for the gut as well as the joint and potential renal, although we don't know yet what this dark urine is or from. We've talked about kind of for that systemic illness leading to inflammatory symptoms also. We've talked about vascular disease. I think the infectious category we need to kind of keep there also. I like the idea a lot of reactive arthritis if the diarrheal syndrome came first, just because of how reactive arthritis can affect a lot of the body outside of the joints, skin lesions, which we haven't heard about, nail changes, GU symptoms, you know, is sort of the dark urine somehow related to urethritis, etc. Eye symptoms aren't present here, but I still wonder if that sort of inflammatory syndrome post-infectious is still there. Anything else, Zaven? We've got that kind of vascular inflammation and infection and reactivity to it that we have on the list for categories at this point?
I think I don't know if you consider sort of IBD as part of vascular inflammation, but I guess that's the other thing that you still could have is you know, ulcerative colitis or Crohn's that's associated with, you know, sort of all the other kind of syndromic components here with extra intestinal manifestations. But yeah, the other thing I was catching up with the chat is just like, you know, visceral porphyria, acute intermittent porphyria, unrelated to the hepatitis C, I think is a great thought. You know, it's a rare disorder, but one that is life-threatening, treatable, and you have to if you don't consider you're never gonna sort of stumble upon, right? And I think it's the normal process of ever having a chance to help a patient with porphyria is to consider it and potentially test for it, I don't know, dozens of times before you actually diagnose a case, just because the manifestations are so you know, non-specific. Abdominal pain, neuropathy, you know, sort of CNS manifestations that are much more commonly caused by like a million other things, right? But especially when there's an overlap, right? It's like gut and nerves, or like um, a belly syndrome and CNS, both unexplained. You sort of enriches just a little bit to reach what should be a very low testing threshold. But one thing I have a question on, and I don't know the answer to, is does acute intermittent porphyria cause fevers? Um, and I'm curious if someone can kind of look into that and tell us. And then the other question that is always so high yield is to ask the patient, has anything like this, even a much milder version, or even just like one of these things that is happening now, happened to you before? Because a lot of conditions, especially in immune category, can have sort of a self-remitting, relapsing course, and often the answer to that question is yes, actually, and that is a clue to sort of reframing to a very different sort of time course, and sort of enriching for a possibility of something like that, and that goes for porphyria too.
Give us some more, Brett.
Awesome. And to answer your question, he had not ever had anything like this before, just to that point. But then we'll go into physical exam and like the basic labs as far as the basic data gathering we had at this point. So on physical exam, the patient was febrile to 101.1 degrees Fahrenheit, 38.4 degrees Celsius. His blood pressure was 157/94. Respiration rate was 17. He was tachycardic to 103, sitting at 97% on room air. On exam, he was appeared uncomfortable, but was in no acute distress. His HENT exam, he had no scleral or sublingual icterus, no oropharyngeal lesions or exudate. From a cardiovascular perspective, he had a regular rate and rhythm, normal S1 and S2, no murmurs, rubs, gallops. From a pulmonary perspective, was also completely normal. His abdominal exam, he had tenderness of palpation really only about the periumbilical region, no rebound or guarding, and his rectal exam was positive for bright red blood per rectum. In his MSK exam, he had pain with both passive and active range of motion in the bilateral knees and elbows. He was essentially mildly tender palpation throughout his lower extremities without any obvious deformities, edema or erythema, or any other boggy, hot, swollen joints. His skin exam, he was warm and diaphoretic, but had no clear rashes, palpopurpura lesions, no pulmonary erythema or spider telangiectasias. He had some shoddy cervical and left inguinal lymphadenopathy that was mobile and non-tender palpation. And his neuro exam, his strength and sensation to light, his sensation light touch was intact throughout. Strength exam was somewhat limited by pain, but also intact. And it really overall was unremarkable.
I'll just say, Brett, shout out on the really thorough exam for this person. Great attention to eyes as well as skin, because we've talked about different ways that those organ systems could be involved. Having the rectal exam data up front to know that there's active bleeding right now. Having the neurologic exam and then the joint exam, really knowing there's quite a bit of pain. But correct me if I'm wrong, no other kind of redness or swelling in the joints at this time, in a guy who's really inflamed and sick. So I think really just great detail and hypothesis driven. Oh, the left inguinal lymph nodes too.
That was a teaching point for, we'll get a little early, but that was kind of in these cases, my always view is whenever you have, 500 different symptoms, you just head to toe, just look at literally every single thing and kind of go back and you play with your illness scripts, you dig back through, connect, whatever, but you kind of just, this could be 800 different things and then go just top to bottom and see. Definitely the approach we took.
Really valuable teaching point. Yeah, worth a lot of time at the bedside to really be thorough. Zaven, does the exam help push you in one direction or the other?
Yeah, I think to Andrew's point, was it? Yeah, sort of the absence of leukocytoclastic vasculitis in the skin makes all small vessel vasculitis slightly less likely. But I think the pretest here was high enough that the post-test with a negative skin exam doesn't necessarily rule out or, drop you below the testing threshold. Again, I think the UA is a very key pivot point that I'm holding my breath on. But I think the adenopathy is interesting. I think the size of course matters. Many people just have palpable cervical lymph nodes and it's nothing. Inguinal lymph nodes too, people can have, and the upper limit of normal for the inguinal chain is a little bit bigger than for lymph nodes elsewhere. Of course, there are some places in the body where it's never physiologic to have palpable lymph nodes, specifically, supraclavicular and epitrochlear. So I think if there's a question of systemic lymphadenopathy, I'd want to do this axillary, I'd want to do a slightly closer lymph node exam, as well as, if there's ever an opportunity or another indication for cross-sectional imaging, sort of take that into account closely, just because it's a feature of some conditions that we're considering, but not necessarily others. So that stands out as sort of like a new question to follow up further on. And otherwise, the arthritis, someone was asking kind of how would we categorize it? Was it just the elbows and knees, or like the hands were fine?
Primarily, and then the way that I'd characterize it when I was talking to my interns and the team was primarily at the elbows and knees without frank evidence of synovitis. I would say like, none of the joints themselves appeared boggy, red, hot, inflamed. It was really just that passive range of motion and active with some tenderness elicited.
Cool.
And those were primarily the two.
Thank you. And then the neuro exam, it sounds like it was there wasn't like overt sort of sensory abnormalities, although that sort of comes with an asterisk too, that you can have neuropathy based on symptoms, and there's definitely something going on, but you don't yet, unless you do very kind of close testing, you don't yet detect on exam sort of sensory abnormalities.
Yeah, and so my usual like basic one, so intake, the light touch, and temperature,
Yeah.
the route we can say.
Yeah. I think for me, I'll say the exam, based on the discussion you just led, Zaven, I think some of the things on our list are lower, right? We're just not seeing the signature of small vessel vasculitis in the skin, and some of the diagnoses we mentioned, which should have skin findings. So that's helpful. I think it's mostly helping me sort of prospectively with two, I think, real-time decisions we would all make seeing this person in the emergency department, which is one, are we, this is a mysterious case. We're curious what's in the body. Are we justified in getting a CT scan here? And the answer for me is yes, for two reasons based on Brett's exam. The lymph nodes, again, we don't know how big they are, but is there lymphadenopathy elsewhere? I think that could be, that is not palpable, even if we go back and do a more detailed exam. And is there really seems like there's a clinical sign of enteritis or colitis based on the bleeding, the pain. What does actually the bowel look like in there? So I feel fairly justified in saying cross-sectional imaging of the abdomen and pelvis, I think could be sort of helpful for us then to get forward with next steps on whether we need to look in the lumen, get tissue biopsy, et cetera. But it depends what we see. I think the other thing is, I think a real life decision people would make is for this gentleman who feels unwell, looks sick, has a high fever. Do you need to give empiric antibiotics or not in this situation? I would say the reassuring features are the history we already have of this going on for weeks and him being fairly, stable, not being critically ill in that time period, plus the normal blood pressure. I think this is probably a real life decision. And I mean, maybe he got empiric antibiotics by the treating team before Brett's team came to take over, but his mental status, the blood pressure, plus the duration of starting to get subacute in the symptoms would make me feel pretty okay not giving antibiotics up front till we sort of had the definitive diagnostics we needed or a real diagnosis. How do you feel about those thoughts, Zaven? CT scan. So I'm saying CT scan. Yeah, I think it's going to be helpful for two major reasons: lymph nodes and gut appearance. And antibiotics, I'd say no right now.
+1 and +1. I think we, you know, we're obviously missing like even more immediate and, you know, basic labs that might obviate or force the hand even more. But I totally agree on antibiotics. I think in reality, patients like this in the U.S. coming into the ED would frequently get antibiotics, and I think for the reasons you outlined, it could be very appropriate to not do that. Hey, did I see Yersinia somewhere? Can somebody like teach us a little bit about Yersinia? Whoever was bringing it up.
I think I saw generally the topic of like pseudoappendicitis on there, but please chime in or pipe up if I missed that or people more to add.
Okay, now I can't find it, but I think it's a good thought. I think it is a very I recently learned that, you know, as opposed to most other kind of bacterial causes of colitis, yersiniosis can take a more sort of prolonged, protracted subacute chronic course. Can be very inflammatory, can be systemic, and you know, be found not only in the, you know, ileum and the immune tissues of the ileum, but also in the pharynx and the tonsils and those immune tissues elsewhere. So anyway, I was just kind of intrigued by that. I don't necessarily know if it explains all the other symptoms, but was just curious if someone else knew. But I think in the interest of time, maybe we can ask Brett to move us forward, and please let us know, by the way, Brett, if we're like close or far or need to speed up.
No, I think we're good. This has been a perfect discussion, I think, because I think we'll give the basic labs and imaging we had on presentation. And then I think we can go talk a little bit more there and then we'll finish up because I think that it'll give us a good branch point. So his initial labs and diagnostics we had on presentation is CBC, his hemoglobin was 12.3, hematocrit at 37.1. His white count was 20, and his platelets were 172. His CMP, really, I'll just stick with the most notable, is bicarb was low at 18. His BUN and creatinine were 56 and 1.50, respectively, with an unknown baseline. His AST and ALT were mildly elevated at 81 and 83, with a normal alk phos at 73. Lipase was normal. Chest X-ray was unremarkable. His UA had 60 RBCs, 300 milligram per deciliter of protein, negative white blood cell count or leukosterase, white blood cells or leukosterase. And he had gotten an abdominal ultrasound and a CT abdomen pelvis in the ED. The abdominal ultrasound showed coarsened liver echogenicity, and the CT abdomen pelvis demonstrated mesenteric edema and fat straining diffusely throughout without other localized adenopathy. And he had plain films of the involved joints that were unremarkable.
Zaven, you want to
Okay,
tackle labs and I can give some thoughts on the imaging?
that sounds good. So there's mild hepatocellular liver injury without cholestasis or bilirubin. There's presumably AKI with a BUN that's a bit higher than you would expect for a glomerular cause of AKI. However, there's been bleeding and some melena, so that might just be from a combination of upper GI introduction of protein as well as relative volume contraction. And then there's the UA, the main kind of potential pivot in this case, I think, that does demonstrate microhematuria and without a ton of protein. I guess that was a protein creatinine ratio, um, and sort of
I
does
think that
kind of
was the estimated. Like I think the lab, like some of our labs just give like that would have been the
from
equivalent
a
of like a
dipstick.
2+ protein from a dipstick,
Okay,
and
okay,
it'll
okay,
give you
okay.
an
So
estimated value.
good, good. So we need to quantify that. Sorry about that. Yeah. So that, but yeah, I think this sort of like, you know, forces the issue of, presumed rapidly progressive glomerulonephritis with a prominent systemic signature as well, kind of more strongly re-bringing into focus the possibility of systemic cryoglobulinemic vasculitis related to the hepatitis C, or any one of the other kind of small vessel renal glomerulonephritides that can also affect the gut. Most stereotypically, there's HSP and IgA sort of mediated vasculitis, among others. So I think would definitely sort of prioritize a serologic workup, and potentially plan for renal biopsy as well. The white count is a bit surprising. I'd love to hear the differential. Specifically looking for EOs, but I'm also just like, I don't know, I'm surprised if there's that many neutrophils, and it could all be secondary to just, or sort of tissue damage and kind of reactive, but just curious what type of inflammation that is.
So it was a primarily neutrophil predominant, with no significant eosinophils.
Thank you.
So definitely
All right.
left shifted.
Imaging, Steph?
I think the plain film's looking normal. We were sort of categorizing this as arthralgias at this point, and I think at least at this time, right, we're not seeing any erosive kind of joint damage that suggested a more longstanding arthritis. So that's helpful to confirm what we thought most based on history and exam. I think the chest X-ray, we didn't have a major signature that was cardiopulmonary, but knowing that there aren't big hilar lymph nodes or anything that are suspicious on that is helpful. And then the abdominal imaging, the coarse liver echo texture, pretty non-specific. We know he's got chronic hepatitis C, so where he is on sort of the chronic fibrosing to frank cirrhosis pathway, you can't tell that by ultrasound, and we didn't hear any notable kind of signs of impaired synthetic dysfunction, at least as part of the pertinent labs. So I think that's a marker of his chronic hep C, but we're still not, quite sure the degree of liver damage, other than knowing there's mild hepatocellular elevation. And the CT abdomen pelvis, I think notable for not having big lymph nodes elsewhere, notable for, correct me if I'm wrong, Brett, like the colon and small bowel actually not looking inflamed themselves, but instead just showing mesenteric edema, which I think comes up on a lot of reads, and is pretty nonspecific. Mesenteric edema, meaning, right, there's swelling in the kind of mesentery. My sort of short list that I think of go for patients with cirrhosis, usually more decompensated though, where the mesenteric edema is accompanied by ascites, etc., which we don't have here. You can get mesenteric edema if there's a vascular problem. So whether that is mesenteric ischemia on the arterial side, either from inflammation, embolism, or thrombosis, and on the venous side too. So venous thromboses can cause mesenteric edema. So it doesn't put us in any direction, but knowing that the gut lumen looks, or it's not the lumen, the gut walls look okay on the CT, it does make me think generally about sort of perfusion and how that fits into his pain, his abdominal bleeding that he's had. Is there actually a vascular problem, which is sort of the direction that we've potentially been heading in, causing that his loose stools and his abdominal pain, etc. So the abdominal ultrasound wasn't done with Doppler, sort of depending where we go next. I do, I think we've really got a signature in the kidney that we need to chase. But knowing that there's mesenteric edema without much else sort of makes me wonder if there's macrovascular issue, but I don't think right now we've got enough for that. And thinking more about what's driving the kidney inflammation may help unify this all.
I have a management question for everybody. Would you give this patient steroids now, pending a definitive diagnosis. And I'd love as many people as possible to answer in the chat. Not yet, please don't. On my count of 3, just say yes, no, yes or no. Only 2 options. Best guess. Would this patient have a net benefit from steroids based on the information that we have so far? Okay, 1, 2, 3. Well, people weren't ready? Okay. Sorry, I expected a flurry of 28 responses. Yeah, I think in these cases, I don't know. I've learned from nephrologists and sort of vasculitis experts that I really trust that sort of time is nephron, and that the downsides are not that bad. You're not gonna sort of screw up your biopsy. You're not gonna for a few days, and that it's worth starting empirically. But in practice, I see a lot of hesitation for this, and I'm still sort of trying to work through that disconnect, and trying to sort of understand the reasoning of the given kind of consultant as they weigh the risks and benefits. But oh, Austin, so you're thinking of like with concern of precipitating like enteric perforation. Austin mentioned he's scared to do so without talking to GI. Okay, maybe Austin. Well, so I think that's really, I recently actually saw a patient with gut perforation who was on chronic steroids, which sort of like came out of the blue. But I would argue in this case, I don't know. I feel like the steroids, if this is vasculitic GI disease, might almost help the bowel wall integrity rather than hurt it. But certainly, I think it should be a very multidisciplinary. All right, that's what I got.
Brett, do you want us to like ask or comment on anything else before we get, I don't know if this is the last aliquot before the final diagnosis, but feel free to sort of ask any pointed questions of the group if you think helpful.
No, I mean, I think y'all done a really thorough job. I mean, I think a lot of the things that have come up were some of the things that we were thinking of as well. And so I think like I said, I think I can give the last aliquot and we'll kind of hit a lot of the points, any outstanding points as we go through.
Awesome.
So going through blood cultures ended up being no growth to date times 5 days. His enteric GI infectious panel, including bacterial, parasites, viral, etc., were all negative. HIV and RPR were both negative. His ESR and CRP were elevated at 40 and 74 respectively. He had a TTE that was normal without any evidence of endocarditis. He ended up getting an EGD and colonoscopy, which showed erosive gastropathy and eventually was found to be H. pylori positive. His colonoscopy had erythematous rectal mucosa, but essentially was otherwise fairly benign, with the exception of 1 2 millimeter polyp. His CK was elevated at 356, and his ANA was positive at 1 to 160 in a homogeneous pattern with a reflex positive RMP at 4.0. His RF was positive at 5.1, anti-CCP negative. His C3 was low at 50 and his C4 lower still at 3. And he'd also gotten a histoblaxococcidioides screenings that were negative. Bartonella and Coxiella were also negative because someone else invoked culture negative endocarditis. And eventually his cryoglobulins were positive.
I love the point earlier, Brett, from I forget who it was. I think Anne Marie made it that the rheumatoid factor is a poor man's CCP, or it is a poor man's CCP too, but it's the poor man's cryoglobulins. So rheumatoid factor is just an IgM antibody against the leg portion of the IgG, right? or the other way around. Regardless, it's a non-specific sort of assay, and it is positive in most, like 80% of cryoglobulins, and can also be positive in other inflammatory conditions like endocarditis. It's one of the minor criteria, right? Outside of rheumatoid arthritis. But the reason I think it's such a good sort of test is because whatever the sensitivity of cryoglobulins is, like, that you might find published, divide that by about 5. Because in my experience, 4 times out of 5, you order a cryoglobulins and it gets like rejected by the lab for one reason or another. Um, so yeah, I just wanted to highlight that great pearl from earlier from Anne Marie. So Brett, do you want us to like kind of comment more on this, or is that your sort of like final aliquot leading into the final diagnosis leading into your teaching?
Yeah, so I mean that was essentially the final aliquot. So final diagnosis being cryoglobulinemic vasculitis, mixed cryoglobulinemia secondary to hepatitis C. And I think we brought up a lot of interesting cases. I mean, a lot of interesting points, the RF being a big one too, which was for at least for our team, when we were kind of seeing things, given the significant fevers and his like litany of symptoms, we almost in a way treated it almost like a fever of unknown origin. Not necessarily, but when you had so many different potential conglomerates, you kind of go down through. And my personal first thought was, was he having like um, was because his creatinine ended up improving with fluids, with the exception of his BUN being elevated. And it was like, was he just started on the HCTZ and then an allopril in the middle of him having profound diarrhea? Wouldn't really explain the sentiment. He just had so much going on that I think the one big teaching point could be the RF, because as we kind of went through and he clearly had concerns for potential, inflammatory process, and GI ended up scoping him, were concerned enough as well that while all some of this other stuff was cooking before we kind of went down, even if you're thinking of like cost savings manner, but like before we even went down the C3, C4 and cryoglobulins, as we were kind of waiting for the initial workup to kind of consolidate itself, one of the things we had ordered initially was the RF. And then with that being positive, tying that into everything else, and then kind of helped us bridge down that pathway after we, some of these other confounders we mentioned, sort of, like the infectious causes, et cetera, as that was also being rolled out to kind of really brought that everything to the forefront.
Wow.
Well,
I guess I just want to think out loud briefly about, we had this diagnosis, sort of wondering at the beginning what sort of fits, what doesn't. So the having hepatitis C as the risk factor for having mixed cryoglobulin vasculitis, you mentioned, Brett, and maybe you'll do more teaching about this, but the cryoglobulins are just proteins that precipitate below body temperature, and you can't have a monoclonal type that happens with lymphoproliferative disorders predominantly, or mixed polyclonal, which is what's happening here with Hep C. The sort of hallmark of the illness script of cryoglobulinemic vasculitis that is missing here is the skin involvement is usually significant and often precipitated by cooler temperatures. So I think it's really I think a pretty salient point. We have people zooming in from all over the world, different climates. This person was in Atlanta, Georgia, right? I don't know what time of year, but there was, who knows, if he had had cold exposure, if this was winter and there's a cold snap, maybe, right, having had some, livido or just some lesions manifest on his ears or his fingertips would have just kicked him off the diagnostic process sooner. So knowing that some of these skin findings are precipitated by cooler temperatures, and knowing not everyone's in a place where they're going to have cooler temperatures, is just sort of a good reminder of not relying on the cutaneous and vasomotor symptom involvement to make this diagnosis. But otherwise, a lot of it fits, right? The musculoskeletal, both muscle is very, the myalgias and a little bit of myositis, it seems, as well as the joint involvement. The peripheral neuropathy is well explained by this. And the glomerulonephritis. Did he end up getting a kidney biopsy also, Brett, or was this whole constellation enough for him to get an MPGN diagnosis without tissue? Presumably.
That was ended up being enough. So we didn't, like I said, his creatinine had improved, I think, at that point, but it was still mildly elevated, but I think 1 point teens. with fluid. So I think there was a component of him just getting a diuretic and an ACE inhibitor on top of him being like volume depleted.
Yeah.
And so with how everything was going down, we ended up touching base with nephrologist before he left, being like, look, rheumatology is pretty convinced. We're all pretty convinced. Is there any, like, do you need more evidence? And they're like, no, he's fine. You can start him on the steroids and move on. Like, we can follow him in clinic, but they didn't feel the need to go for a biopsy or anything else.
Yeah.
Especially
You
because a lot
know,
of our workup ended up ruling out other causes for, nephritic or nephrotic syndrome, as we kind of covered the rest of the spectrum during his stay.
Great.
thanks, Brett. Do you know how he did like how he's done?
Unfortunately, no, because that was the one unsatisfying part. And I think another good point for when you're kind of going through some of these and trying to make sense of some of these symptoms. So native Spanish speaker, using a translator, and really when you have complicated cases like this, taking your time and going through everything. And unfortunately, I mean, we kind of tried all of our best efforts to. I mean, I called because we just seen at Emory. I called Grady, got him plugged in with financial counseling to get a Grady card, get all those kind of things, but didn't end up making it for his appointment. So unfortunately, was lost to follow up.
Yeah, that's a bummer. I think in this case, when follow-up happens, it would be important to treat the hepatitis C as well. I remember two cases of sort of hepatitis C driven glomerulonephritis. One was MPGN and one was cryo, where there was sort of like ongoing disease despite steroids and stuff, and talking to GI and renal and rheum, and like we decided that it was really important to like treat the hepatitis C urgently, which was usually not the case, right? Usually it's not super time sensitive, and it's done on an outpatient basis to the point of like getting HCV antivirals from like for an inpatient, like they're not on an inpatient formulary, and we like had to try to um uh, anyway, I hope this young man is able to kind of get plugged back in, because uh obviously he was very sick, and there's a lot that he can benefit from in terms of kind of follow-up and ongoing treatment. But this was an amazing case, Brett, and you presented it so beautifully, and it was a really really great discussion. Thanks to everybody sharing their experience and knowledge. So thank you to everyone who tuned in. Special thanks to Parisa and Brett and Bayan for running the show and making it happen. Any other closing thoughts? Oh, sorry, one more question. I loved, Steph, your point about the temperature. So was this in the summer, Brett, or at least like this presentation?
So yeah, and I can tie up with two of these points because to help with some of the other people. The temperature one. So most typically, it was in the summer, but also with the type 1 cryoglobulonemias is where you most commonly see the cold, distal necroses, the livedo reticularis, some of those other things. Still incredibly atypical that he did not have the any of the palpable purpura component, but the thought was that this is the hyper acute presentation of the disease, and that likely if left continued would have likely developed these. And I think so that was, I think, the point on the cryoglobulins part, but it was in the summer. And then I think along with the kind of thinking of Hickham's dictum with some of this as well, that he also had the erythematous mucosa, remembering that his hematochezia happened at the last 2 to 3 days prior to presentation, where he had, 7 to 9, or I forget how many I said, bowel movements for the last 2 weeks. And so we also wonder some of this because his colon didn't look that terrible. Was some of the, was this just a brisk systemic inflammatory response causing all the diarrhea? And from just the repeated trauma, did he have, like he did have scant blood on rectal exam, but was some of this from that, erythematous rectal mucosa that we saw from just repeated bowel movements over and over and over? Or was this, like clear vasculitic GI involvement? That part was still, it's still a little bit in flux, but could definitely have been a confounder as well.
Thanks for the follow-up, Brett. Parisa, do you want to close this out with highlighting some teaching points?
Yeah, of course, it was an amazing session. We started with a patient, sorry, I lost the board. We started with a patient who presented with intractable diarrhea and polyarthralgia with 2 weeks. We started with the fact that we start to frame all these complicated presentation. When we have a paresthesia and blood in diarrhea and myalgia and arthralgia, we know that these are indicative of inflammatory symptom in the patient. We learned that usually UA, it's a diagnostic tool for us in differentiating between infections and non-infectious causes because the presence of the cells and the protein could really helping us. When the patients are presenting with acute and chronic diarrhea, which is combined with arthralgia, this could be suggestive of reactive arthritis, possibly post some bacterial infection like salmonella, which is accompanied by skin lesion, nail changes, and potential neuropathies. We learned that HCV have extrahepatic manifestation, including dermatologic symptom like porphyric cutaneous tarda, peripheral neuropathy, vasculitis, such as the case we had here, cryoglobulinemia, and renal membranous proliferative glomerulonephritis. The patient medication history usually is really important, including HCTZ and ACE inhibitor. These could present potentially with drug-induced pancreatitis. We know that ulcerative colitis could be presenting with extraintestinal manifestation, which is affecting eyes, joint, and skin. We learned that patient symptoms of acute intermittent porphyria include abdominal pain and neuropathy. It is really important for us to ask about previous symptom to detect a pattern that might help us to diagnose usually rare symptoms. The absence of leukocytoclastic vasculitis in the small vessel of the skin makes the diagnosis of a small vessel vasculitis less likely. The inguinal lymph nodes are, it could be also present in the normal population. And further examination of the whole patient is really important, but the other kind of the lymph node, for example, supraclavicular and epitrochlear lymph nodes, they are more diagnostic and they could be present with more symptomatic pictures. We learned that decision regarding empirical antibiotic therapy is usually based on the mental status of the patient, the blood pressure, and the duration of the symptom. We learned that some kind of the bacteria could have unusual clinical presentation and they could be present with prolonged picture like Yersinia. We learned that rapidly progressive glomerulonephritis might be linked to vasculitis like HCV cryoglobulinemia, and tests like ANCA and anti-GBM and renal biopsy. It's required to ruling out other vasculitis like IgA and HINOF. We learned that mesenteric edema, it could be suggestive of arterial inflammation, embolism, and thrombosis. We learned about how starting a steroid in case of gastrointestinal vasculitis usually require careful consideration of the benefit versus risk of the enteric perforation. We also learned about the RF, which is the targets the FC portion of the IgG. It is used in the testing of the cryoglobulinemia, and it is positive in 80% of the cases, but its actual sensitivity in the real clinical practice is usually lower. Thank you so much for this case.
Thank you, Parisa. Great summary. Thanks again, Brett, for a fantastic case, and for all of you in joining and sharing your thoughts. Always learn so much and have a great time. Looking forward to next time. Have a great day, everyone. Bye.